So this video is in continuation with the tubercular spine video series. Here in this video we will discuss about the neurological grading of the paraplegia if it occurs in the tubercular spine patient. So this is known as by the name of POTS paraplegia. So we have 4 grading here in this POTS paraplegia. Now before discussing the POTS paraplegia we will discuss about the middle path regime. So middle path regime is basically we prescribe drugs for all the patient and surgery is indicated only in case of the failure of the chemotherapy. So middle path regime says that every case is to be started with the chemotherapy, which we have already discussed in the previous videos, with rest and gradual mobilization, aspiration of the large abscesses, management of the sinuses and checking of the clinical and radiological progress. So we prescribe drugs for all the patients and surgery is indicated only in case of the failure of the chemotherapy. Now coming upon to the various neurological grades of the paraplegia. So we have classified into 4 grades. In grade 1 the patient is unaware of the neural deficit and it is a physician who on examination detects the Babinski positive means plantar extensor and or ankle clonus. Clonus is basically a grade 4 type of reflex. So it is the physician who detects the plantar extensor and the ankle clonus, but the patient is unaware of the neural deficit in this grade. It is known as grade 1 of the paraplegia. In grade 2 the patient is now aware of the deficit. He complains of the weakness of the lower limb or the upper limb, but he still manages to walk with support. This is the grade 2 of the paraplegia. In grade 3 this is known as the moderate paraplegia. The patient is non-ambulatory. He is not able to walk even with the support. He is non-ambulatory and the paralysis is in extension in this grade. So the paraplegia is the extensor paraplegia. And the sensory deficit is the less than 50%. So more than 50% of the sensation are still intact. And in motor the paraplegia is in extension. Now in the grade 4, which is the severe type of the paraplegia, the patient can present to us in either of these 4 gradings. So he or she can either have a flexor spasm or the paralysis is in flexion. So in extension it is the extensor groups that are involved, and in the flexion it is the flexor group of muscles are involved. So flexor group of muscle are later involved and extensor are first involved. So in grade 4 the patient may present to us either in the flexor spasm or in paralysis in flexion, or the patient can have altogether a flaccid paralysis. So here it is the spastic paralysis which is in flexion. Here it is the spastic paralysis which is in extension. But in grade 4 the patient may present to us in a flaccid paralysis altogether. The sensory deficit here is more than 50%. That means less than the 50% of the sensation are intact. And the sphincters, bowel and bladder, they are involved. So if the patient present to us in any of these 4 conditions, he is said to be in severe type of the paraplegia. So it can be either flexor spasm or paralysis in flexion. It can be flaccid paralysis, sensory deficit more than 50%, and bowel and bladder involvement. So this is the POTS paraplegia grading of the neurological loss. So it should be remembered that this grading is applicable only in compression of the cord and not in the chorda equina. So this grading is applicable only up till the L1 level. After L2 to sacral level we have only chorda equina fibers, so this grading is not applicable at that level. It is only applicable when there is compression of the cord itself. And flaccid paralysis, which we have talked about, it can be either because of the severe cord compression or it can be because of the pathological dislocation because of instability, bony instability, and rarely it can be cause of ischemia, which can be cause of thromboembolic phenomena in the vascular supply of the spinal cord. So the flaccid paralysis can occur either because of the severe cord compression, because of pathological dislocation, or because of the ischemia due to thromboembolic phenomena. So what all functional deficit will be seen? So basically we will discuss about the motor and the sensory deficit. So as we know that TB is an anterior disease, is most common involvement is the anterior involvement, paradiscal, central or anterior involvement. So the tracts that are anterior in the spinal cord will be affected earlier. So motor function are always sensitive than the sensory function. So motor is always affected more and to a greater extent than the sensory function. This is due to the fact because motor function are more sensitive to the compression of the cord, and plus they are lying anterolaterally. So this is the anterior or ventral aspect, and this is the posterior or the dorsal aspect. So as we can see here, the light touch or the crude touch, it is ventral or anterior, so it will be involved first. And here we have corticospinal tract, voluntary corticomotor tract, they will be involved first. Later involvement there will be of pain and temperature, and at last on the involvement of the posterior column there will be involvement of the dorsal column, deep touch, proprioception and vibration. So these are involved at the last, while the crude touch, pain and temperature, they are involved first along with the motor involvement. So as the cord is increasingly compressed in grade 4, we have discussed in grade 4, the patient develops flexor spasm which later remain established in the flexion. So this indicates complete loss of connectivity in the pyramidal and the extrapyramidal tract. So these are the extrapyramidal tracts, they are deeper in the spinal cord, so they are involved later. So the flexor spasm and the flexion, it occurs in the grade 4 only, and in advanced cases of compression we have discussed in grade 4, bowel and bladder are involved. So really the paraplegia of the tubercular etiology, it may present as spinal tumor syndrome. If there is a localized tuberculoma or a diffuse granuloma or a peridural fibrosis, it may present as a spinal tumor syndrome. So this is again the transverse section of the spinal cord. So we have discussed that dorsal column, vibration, proprioception are involved last. Pain, temperature, motor and crude touch, they are ventral and lateral, they are involved first. And extrapyramidal fibers, they are lying deep, they are involved later in the stage, and plus bowel and bladder, it is involved later in the stage. So posterior columns we have discussed, they are last to involved, so position and the vibration sense, it is last to be get affected. So this is the one classification of the paraplegia. So another classification depending upon the time of onset. So it is early onset paraplegia or a late onset paraplegia. So in early onset paraplegia, it is a paraplegia of the active disease which occur within 2 years of the occurrence of the tubercular spine. So here the cause is basically mechanical cause because of the retropulse, pus, granulation tissue, bony sequestrum, caseous tissue and instability. So these are all the causes in case of the early onset of the paraplegia. While in late onset of paraplegia, the patient is symptom free for a period of at least 2 years after the healing has taken, and after the 2 years patient develops late onset paraplegia. So once the healing has occurred, healing of the tubercular spine has occurred, patient is asymptomatic for at least 2 years, and then later on patient develops paraplegia, it is known as late onset paraplegia. So here the cause is basically because of the kyphotic deformity. The patient develops a kyphotic deformity which causes a bony ridge. Here this is known as bony ridge. So if these are the vertebrae anteriorly and posteriorly we have the spinal canal, so this ridge is known as bony ridge. It may lead to the transaction of the cord at this level, and also the constriction of the cord because of granulation and fibrous tissue can occur at this level. So this is the cause of the late onset paraplegia, which is most likely because of the kyphotic deformity in case of the earlier untreated deformity of the tubercle spine. So that is all about the paraplegia in the tubercle spine.